Hi everyone, the webinar will be beginning in just a few moments. Hello everyone and welcome to Epilepsy Research UK's Research Roundtable on epilepsy surgery. Sometimes epilepsy does not respond to medication, and in some cases, surgery may be considered as a promising treatment option with the potential to control seizures. But surgery doesn't come without risks and challenges. And so in today's webinar, we'll be hearing about how world-leading research funded by Epilepsy Research UK is helping to improve surgery, and one person's remarkable story of the difference that epilepsy surgery can make. All of today's speakers have also contributed to our research blog, so if you're interested to hear more, we'll shortly share the link to the blog in the chat below. Today, we'll be hearing from Professor Torsten Boldeweg, Professor of Developmental Cognitive Neuroscience at UCL Great Ormond Street Institute of Child Health. Professor Boldeweg will be discussing his Epilepsy Research UK funded work to assess the long-term impact of epilepsy surgery in children. We'll then be hearing from Dr. Sjoerd Vos, a lecturer in quantitative neuroradiology at the UCL Centre for Medical Image Computing. He will be discussing their current Epilepsy Research UK funded study investigating predicting and reducing language deficits from temporal lobe epilepsy surgery. But firstly, we're going to be hearing from Rachel. Rachel first started having seizures when she was 2 years old and 11 years ago had epilepsy surgery. So Rachel, I'm going to hand over to you now.
So I started having seizures at around the age of 1 or 2, and then I got diagnosed when I was about 3 years old. And between having seizures and being diagnosed, I was having these quite regularly, and it would interrupt school, and making friends at such a young age would be quite a challenge. It wasn't until I was in and out of hospital quite regularly at Great Ormond Street, where I had an amazing team, and obviously without their hard work and efforts, it wouldn't have been possible to make a full recovery. So the surgery itself, I don't remember a whole lot of it, but I do remember kind of before I was a very nervous child, and I didn't really know what to expect because I was only 7 at the time. And then as far as coming around after surgery, I felt completely brand new, and my parents and friends and family will be able to see that as well. But it was just very confusing. I didn't know what had been happening, and then trying to look back on it as now a 19-year-old, I realised just how intense that was for such a young child to go through. But you know, without the outstanding work of the researchers and doctors and the team that I had, I wouldn't have been able to make a full recovery. And even if I did, the chances of kind of maybe having some problems later in life would have been very apparent. But I'm really lucky that I can still do all the things that I enjoy, and lead a normal life that a teenager would. So yeah, in terms of the actual surgery, like I said, because I was very young, and I was a bit confused at the time, I didn't really understand, and it's something quite difficult for a child to understand as well when everything is going at such a fast pace. But as soon as I came out of surgery, I was eager to learn. I wanted to go back to school and make friends. And I was just like a completely different child. So for that, I'm really thankful that the surgery worked for me, but I understand that that is not possible for everyone. But with the mixture of medication and surgery, it can work for some people.
Thank you so much, Rachel. It was so brilliant to hear your story of your epilepsy surgery firsthand. And I know it said you wrote in your blog that you had around 30 seizures a day before your surgery.
Yeah, so I would have them at school, at home, in my sleep sometimes. Some of them would be really bizarre that my parents have explained to me now, that sometimes I'd have them whilst walking, and the only way they can explain it is just kind of like a drunk person, maybe slurring their words, going to fall over a little bit, but I'm still aware that it's happening. And some of the most severe ones, it's quite scary that I remember them really well. One of which was in my old house, and we had a chimney breast in the living room, and I remember I fell off the sofa, and I sort of woke up, and all I could see was the ambulance lights towards the front door, and all their high vis and everything. But for the most part of it, particularly ones in my sleep and that were small and happened every day, I don't remember too much. But yeah, they would sort of be falling in and out. They could last anywhere between 3 minutes, half an hour, or, you know, a couple of hours.
Wow, that sounds so frightening. And
Yeah.
then, although you say you don't remember a lot from the time of having your surgery, I'm sure that was frightening too, but then amazing to come through the other side as successfully as you did.
Yeah, absolutely.
And of course, I have to bring this up early because you are going to be running the marathon, the London Marathon, for Epilepsy Research UK in a few short months, aren't you?
Yeah.
Brilliant. How is your training going?
Yeah, it's just under 5 weeks now. Yeah.
Wow. How is your training going?
Yeah, really good. I'm ahead of schedule at the moment, which I'm really happy about, because obviously it was supposed to be last April, and it was unfortunately cancelled. And then we could choose to do it in October last year, but it was either for elite runners or virtual only. And I thought, for the most part, to do it in London, you know, I don't know if I'll ever be able to do that again. So I deferred until I could be there in person. So last year, when I was in the peak of training, I got up to half marathons. But just this Sunday gone, I ran 16 miles, which felt like it was never going to end. But I'm really happy that I've got that far. This weekend, I'll probably be doing a similar distance, and then it will be 4 weeks. So yeah, really soon.
Wow, well done, and good luck for the marathon. We really can't wait to hear how you get on. And so thank you so much, Rachel. We'll be coming back to you at the end with more questions. But for now, I would like to introduce Professor Torsten Baldweg from the UCL Great Ormond Street Institute of Child Health, who has been funded by Epilepsy Research UK in the past. Welcome, Torsten.
Hi, Quiva. Hi, everyone.
Hi. If you'd like to go ahead and share your screen.
Yeah, thank you, Quiva. Yeah, okay. Thanks to the amazing funding that we've received through ER UK and the efforts of many volunteers to fundraise, we've been able to do some for us and the community, very important work on studying the cognitive outcomes of children who undergo epilepsy surgery. So in this talk, I will focus on this part. And why is cognition, i.e. learning, memory, language, and so on, so important? Because you can probably see on this slide that the one part of the brain called the hippocampus is not only a very frequent source of medication-resistant seizures, but is also very critical for memory and learning. So we wanted to know really what is the impact if this structure and the surrounding tissue is removed in surgery, how it will impact on the ability of children who are still learning to develop. Okay, in order to explain this a little better, I have this sort of slight schematic graph of showing kind of time from birth, but also some cognitive score that sort of we can measure at different times. But unlike in adults, where this line of kind of norm would be a horizontal line, in children we're dealing with a moving target, in the sense that children learn all the time. So, and what is well known or established, that many children who have onset of their epilepsy in childhood, like Rachel just described, will suffer some form of delay with respect to their healthy peers or healthy sibs, which can be greater the earlier the onset is. Hence also the imperative for early surgery. So, and this has been documented by us and others, that it impacts on the development of the brain, but also on their cognitive scores. So then we come to the important part of selecting the right surgical candidates, and this will be covered by my colleague, Dr. Sjoerd Vos. And when this decision for surgery is being made, an important part is the pre-surgical mapping, and I'll show one example of this. But further, the main focus will be on what can we establish about the development of cognition and learning in children after surgery. Does it not make a major impact in a sense like in this case shown here in B, or maybe surgery makes it even worse? Or in the best case, does it lead to some form of catch-up development? Which would be quite remarkable, I have to say, because it would mean that the gap to the healthy peers will narrow with time, and that means their cognitive scores will actually increase. So this part of really trying to evaluate and potentially predict their cognitive outcomes is an important part. So I'll try and summarize this at what proportion of children will fall into these different groups. Okay, and another unfortunate complication of childhood onset epilepsy that is medication resistant is that some of these brain abnormalities that are shown in this graph, there are some more subtle ones and some bigger ones, also tend to cluster around areas of the brain sort of summarized in this graph here that are important for language development and speech, and in some cases also movement. So in order to do this, we are routinely now using a technique called functional magnetic resonance imaging, and Sjoerd Vos will talk about this too, where we use different tasks that children can do inside the brain scanner, where they can generate words or sentences, but also listen to stories like what I've shown here, to really map out which parts of the brain are supporting language functions. On the left, an expressive language, clearly showing that the clusters of activity are just outside this area of abnormality. And in this comprehension task, understanding of speech, it's quite clear that the activity has relocated to the opposite hemisphere, which informs the surgeon that perhaps surgery in this part is fairly safe and should have minimal impact on cognitive development. Okay, so coming now to the predicting outcome part, and from one of the core features of our studies that we were able to do was that we did not only look shortly after surgery, which most of the studies do when children are discharged from hospital, but actually up to 15, 16 years after surgery. So we have a really good idea of what is the long-term impact on development and educational outcomes, etc. And two factors that we were particularly keen to understand was what is the impact of where in the brain the resections happened and how big the resection was, how much of the tissue has been removed, and can we show any evidence of brain plasticity, similar to what I discussed earlier. Okay, and as I said, I will summarize the data from two studies. So we were fortunate enough to get 2 rounds of funding from Epilepsy Research UK, the first time for a temporal lobe surgery cohort, and a second time for a cohort where we had also other forms of surgery included. Okay, so one of the first measures of cognitive development that my colleagues usually take is a measure of IQ assessment or general cognitive development. And you see the data points from before surgery and shortly after surgery until 15 years after surgery, kind of subtracting the pre-surgical level out. So you see a kind of a pattern of this cohort of subtly declining functions as they get closer to the time of surgery. Then it levels off. And then it looks like that the majority tend to be on an upward trajectory, which is also shown in this graph, which is kind of the mean of these data points. And it turns out that it actually takes 6 years plus for these scores to actually increase above what children had before surgery. So this is quite remarkable, because it actually does show that it's possible that with time, children actually have catch-up development and develop and learn faster than their healthy peers, which still strikes me as incredible. And a very similar pattern was observed in our second study. Again, we show this gradual lagging behind their peers, and then it takes a number of years for that to kind of level off, and eventually they develop faster. You also see that there's a small group of children where this doesn't seem to be happening, and this was the first one that we try to isolate what about the surgical procedure is potentially contributing to this lack of, if you like, gain and development. And it turns out from this kind of analysis that it's particularly these larger sections of the temporal lobe, anterior portion of the temporal lobe, that seem to be impacting on cognitive development. So all other parts of the brain don't seem to be showing this pattern. And it supported something that we knew from adult studies of dementia, that this anterior portion of the temporal lobe is an important hub that allows us to store and access the knowledge of the world, if you like, something we call semantic memory. But on the positive side, we also learned that the brain, not only opposite the side of surgery, but even on the side of surgery, after successful surgery, actually starts to grow more than before. So it does catch up, if you like, brain growth. And the parts that are shown here are particularly correlated with gains in fluid intelligence. So the quicker you can think. And we know this is very plausible, because from other studies in healthy individuals, we know that the frontal cortex and parts of the temporal and parietal cortex are important for that. And one of the most kind of surprising results that I've seen in a while is that these structural changes to the brain, the kind of brain growth, here shown for those areas of the brain that are actually exceed the normal development, if you like, but also exceed those in the non-surgery group with epilepsy, include not only the frontal cortex in the opposite hemisphere, but also ipsila, but very extensively in parts of the temporal lobe, including also a structure that we call the cerebellum, that is very critical for learning and coordination and so on, movement. But also probably the strongest changes are in a region called the hippocampus and surrounding tissue. And the hippocampus, as I mentioned earlier, is important for learning and memory. And this is exactly what we also found when we test children behaviorally using memory tests. So, and schematically, it is shown for a group of children who had left temporal lobe surgery to relieve their seizures. So they will show a short dip up to a year after surgery, and then they tend to level out and regain their preoperative level of functioning. This is in contrast to adults who tend to have more long-lasting losses. And Sherd will later on talk about how to minimize this also in adults. And quite amazingly, the memory functions that are subserved by the other hemisphere, because they're not impeded by a seizure activity, start to pick up and increase quite significantly. The reverse pattern is true for children who have the right temporal lobe surgery. So this pattern of plasticity and compensation is quite symmetrical with respect to both hemispheres. Just to summarize, we also found, as I mentioned earlier, that we have to, we told our surgeons that being more sparing with respect to the resection of healthy tissue will also positively impact on development of this semantic memory, which I just, or world knowledge, but also if the resection of the hippocampus is more sparing, then the autobiographical memory, or what we call episodic memory, will improve faster. Okay, so in summary, I've shown you the sort of along this sort of a journey of a patient across through this surgery pathway, that we have different outcomes. Luckily, the majority of children will show a positive cognitive outcome. And this positive outcome is particularly, including catch-up development, is particularly likely if it leads to seizure freedom, and children also come off medication eventually. And we've identified some of them who in the future will hopefully benefit more. And which leaves me to thank all my colleagues, and there's a much larger team that I can show here, particularly Professor Helen Cross, who has been the head of the epilepsy surgery program, all my colleagues in neuropsychology who helped to collect these, colleagues in imaging, but also our surgical colleagues who are obviously absolutely critical for the success of these programs. Thank you so much. I hope this was informative to you.
Thank you so much, Torsten. That was amazing to see the potential impact of surgery on cognition and those learning outcomes. I thought that was brilliant. One thing that you mentioned throughout was this concept of plasticity and neuroplasticity. I wonder if you could just explain what that is.
Yeah, it is an important concept, but so there are two components to it, particularly in the developing brain. One is a developing brain can almost relocate functions, as I showed you in this one case, and that happens even that the whole language circuit, which normally resides in our left hemisphere, can actually shift towards the opposite hemisphere at no cost to linguistic abilities. And we've studied this in children who had strokes early on. And we also see this in children with epilepsy. So you can relocate function to another part of the brain. And the other element is that the brain also can make, in existing parts of the brain that contribute to memory, for example, can make new connections. In some parts of the brain, it can actually regrow cells, such as the hippocampus. That's something for the future. But it is a phenomenon that we can observe. We still find it hard to, if you like, kickstart or sort of manipulate it in a positive way. That is still for the future. But it is particularly possible to kickstart this in children, which kind of puts a little bit of pressure to have any kind of surgical intervention as early as possible, and also to avoid, if you like, the disease process to take too much hold in this. So the chances of, we think a chance of a really positive recovery will be greater the earlier the surgery can take place.
Wow, that sounds completely fascinating. Thank you so much, Torsten. We'll be bringing you back at the end for some questions, but thank you so much for speaking about your research today. And now I would like to introduce Dr. Sjoerd Vos, who is from the UCL Center for Medical Image Computing. So Sjoerd, it's over to you.
Thank you very much, Caoimhe, for the invitation to talk here today, and a very interesting session so far. As you've mentioned, I will continue talking about the epilepsy surgery, but now in adults. So this work is work that's been done between the Centre for Medical Image Computing, the Epilepsy Society in Charles von St. Peter, and the National Hospital for Neurology and Neurosurgery in Queen Square in London. So the work that we've been doing is around epilepsy surgery, which is, as you said in the beginning, a very good treatment option when anti-epileptic medication doesn't work. It can be very successful, and that's, as we saw in a previous talk, it might depend on a lot of factors whether surgery is or isn't successful. temporal lobe epilepsy, surgery is the most common. This is partly because of the types of epilepsy and the frequency of types of epilepsies, but also because it has a very good outcome after surgery. So we saw previously in the previous talk already that the temporal lobe is an area of interest. I've highlighted it here in blue as we have a look at the whole brain, because it's not just the temporal lobe, the blue outside of the brain that we're of interest in temporal lobe epilepsy, but it's also the white structure, the hippocampus, that you can see here in the middle of the brain. The previous talk from Torsten Baldeweg already highlighted the importance here as well. An anterior temporal lobe resection, which is the most common type of epilepsy or temporal lobe epilepsy surgery, is not just about taking out the blue sort of outside part of the temporal lobe, but also the inner structures, so the hippocampus in this case. And anterior temporal lobe resection has a very good seizure freedom outcome, at least in adults, and I think as well in children. And it has a better outcome than less invasive options where only a very small part of the brain is removed. And this is very encouraging for patients, so that they have a better chance of being free of their seizures after their operation. The downside is that these bigger resections, such as anterior temporal lobe resections, also come with more downsides. So cognitive outcome can be quite variable after surgery. And the function we're specifically focusing on in the work that ER UK is funding at the moment is language, and very specifically the ability to name objects or things. In most subjects where we have this type of surgery, their capability to name objects declines. So this is seen in about 34% of people. However, there's also quite a few people, in this case 4% from the study in 2011, where we see that language and naming actually improves after the surgery. And we think, similar to as we saw in the previous presentation, that this might be because there is less impact of seizures on the brain, and it can recover its normal function. But we're still very surprised to see such a decline in naming, as the surgery that we're talking about here is designed specifically over the years, over the decades even, to spare areas of the brain that we know are involved in language function. So two of those main areas of language function are highlighted here in blue and in pink or orange. And these are designed to be spared in the surgery. So how does it work that we still get such a variable decline in cognition? And for this, we have to go back to the anatomy of the brain. So the gray matter and the white matter in general make up the brain. There's a few other tissues in there that I'll ignore for the sake of simplicity. So the gray matter is the part in the brain around the outside, so the darker gray areas in this case. So here around the outsides. The white matter, which also makes up quite a huge proportion of the brain, is what you see here within the more central parts of the brain, and in this case the lighter gray. And they serve very different functions in cognition. So gray matter in general takes care of all the actual thinking, so the processing of information is all happening in that outside darker band of brain tissue. Contrastingly, the white matter is mainly all the connections within the brain. So that goes between maybe different parts of the brain, but also from the brain down to the rest of our body to sense, to feel things, and to operate your arms or your legs. And it stands to reason that if we design a surgery to not remove any of the gray matter areas, the functional areas that we think are involved in language. Here are some of the structures of the white matter that are involved within the brain, seeing that they're actually quite present throughout the brain. So if it's not the gray matter that is removed in these surgeries, it might well stand to reason that damage to these white matter connections maybe involved in language cause the decline that we see in these patients. We've previously shown within Queen Square that this is also true for vision, where a visual field deficit in these types of surgeries can be prevented if we design our surgeries to spare a brain connection that's involved in vision, in this case, the optic radiation. So we're really trying to expand our previous work from Queen Square to show if this can also be used to spare language. The downside of this type of language function, as we've heard in the previous talk as well, is that language is a very complicated function. So we're focusing on this project on the temporal lobe because that's where the operation happens. And if we just look at all the connections or the bundles that are involved in language that run through the temporal lobe, you see that it's these 5 connections or groups of connections. So it might be one of these structures that is damaged in surgery that might be causing a language decline if it gets damaged. It might be a combination, or it might be none of them, and there might be things that we are not aware of yet. So what we've tried doing in the study so far is that we've taken data from temporal lobe epilepsy cases over the last, I think, 10, 15 years that have been operated on in the National Hospital for Neurology and Neurosurgery. And we've taken their MRI data from before and after surgery. Just to clarify, this is all adult epilepsy patients. And having taken MRI data from before and after surgery, you can see already here in the MRI scan from before the surgery that this is an abnormality here within the brain that will be targeted to be removed. And this is, in general, the temporal lobe that we are investigating. So if we then have an MRI scan of after the surgery as well, we can see that quite a large chunk of the brain, including that abnormality, is removed. And having this information combined with the special type of MRI scanning called diffusion MRI, which can help us reveal the connections within the brain, we can then see that for one of these connections, there is an overlap between the part that was removed in the brain and one of those connections involved in language. And this is how we think surgical damage might be causing a language decline. And of course, we have neuropsychology from before and after surgery as well, so we can see which of these patients had a decline in their language capabilities, and then try and link this to the patients that had damage to these connections. And this is an example that we see here for, again, that same white matter structure, the inferior frontal occipital fiber, going from here, the posterior, the back of the head, back of the brain, to the front, just around our eyes. And we can see in this case, with the part that was taken out in the resection, here in blue, we can see that in this example of subject here at the top, the red sort of connections that we show here, those are the ones that have been removed in the surgery, and there's only a very fair few. While we see here in the bottom that in this case, with a larger part of the brain removed, quite a lot more of these connections, all the ones in red, have been removed during the surgery. And that we found has related to change in patients' naming scores. So this is a graded naming test, which is one of the standard neuropsychological tests. And we see that as we go sort of from the right side here to the left of the graph, we see that more and more part of the connection being removed, the worse a patient's language outcome is. And this is in part because it's a bigger part of the brain that's removed. And we saw that in the previous talk as well. But there's very much an impact of what structure has been damaged on what type of language might reduce or decline after surgery. So we see that damage to different bundles causes different types of language skills to decline. This depends on what side of the brain the surgery was, whether it was in the hemisphere that's dominant for language and mostly used by subject for their language, or in the area of the brain less used for language. And also, as I said, depends on the type of language test, what the type of language skill that we're assessing. So we're underway with a prospective study to see if this knowledge from this previous study can help us inform surgical practice going forward. In terms of my thanks, mostly go to the top two here on this list is Mr. Lawrence Binding, who's the PhD student that has joined John and Duncan and myself on this project funded by Epilepsy Research UK, and who has done a huge amount of work to try and make all this this research happen. All of the other clinicians and researchers from Queen Square have been invaluable, and the collaboration with Newcastle University through Dr. Peter Taylor has contributed greatly to this project as well. Thank you.
Thank you so much, Short, for speaking about your research. That was so interesting. And you said language is a very complicated function, which I think is so true from the science of things. And I wonder, you know, we heard about the concept of plasticity from Torsten earlier. When in epilepsy surgery, these language fibers and bundles are damaged, do you think that plasticity can play a role in repair, or is I don't know.
I think absolutely. I think within children's brains there is a lot more potential for regrowth and relocation, as we just heard. But we know from other studies, neuropsychological studies within adult epilepsy patients and surgery cases, that definitely there's still plasticity happening with function relocating away from areas to either the other side of the brain or to other areas within the resected hemisphere. That still definitely happens in adults as well.
Okay, but there still is, you know, you mentioned that there's the 34% decline, so that still is obviously quite prevalent.
Yeah, absolutely. The long-term outcomes are obviously a lot more difficult to keep track of, and there is some improvement in the later years after surgery, whether this is because of plasticity or because the brain can just cope better without having seizures. I'm not sure whether that's clear. But the language, in most cases, the language doesn't get back to a normal, healthy level.
Thank you. And I have to say, your group always produces some of the most beautiful images of the brain. It was that animation of the brain and the different lobes is just beautiful. So thank you so much for sharing those. I'd like to now reintroduce Rachel and Torsten, and we'll have a bit of a discussion and answer some of the questions that we've had. Thank you and welcome back, everyone. So we've had some questions that we'd like to put to you. And Rachel, we're going to start with you. So this is one question that we ask all members of our SHAPE Epilepsy Research Network. What has been the main way that epilepsy has interrupted your life and perhaps your family's life as well?
I think for the most part, like I said earlier, school and making friends at such a young age is one of the biggest challenges I personally faced, because when you're a child, as much as you're constantly learning, it is about having fun and making friends and you know, finding what you like and what you don't like, whether that be at school or in social situations. So to have that taken away from me and not be able to get involved as many things as I'd like was quite upsetting. A way that I found to help with that was through horse riding. So love for animals and stuff, they really helped me to learn as well. And that was something I could do with additional support from leaders and family members and things. But I think as well, from a parental point of view, it's just so frightening because you can never tell sometimes when a seizure is about to come on, and kind of almost giving your, you know, having a child go into the hands of a surgeon or a doctor, obviously that's they're in trusted hands as it is, but for a parent I can't imagine how frightening that would be, particularly because the outcomes sometimes are uncertain. But I'd say definitely just every day was just so frightening, particularly when I was undergoing lots of tests regularly, but from my point of view, definitely school and making friends was one of my biggest struggles.
Yeah, I think that must be something that's so difficult at such a young age as well.
Yeah.
And so, Torsten, we've obviously heard of Rachel's amazing success story, but why is epilepsy surgery not an option for all people affected by epilepsy?
There can be a number of reasons. One of them is that perhaps these seizures become suddenly well controlled on medication and it's not really worth taking the risk. In other cases, sometimes the risk of losing a specific function could outweigh, for example, movement or vision or language could outweigh the potential benefit. And as Rachel also said, not all children will be fully seizure-free after surgery. And also a fairly large group of children where we can't really find a definitive abnormality. And that's something that we're really kind of working very hard to improve. We might be able to talk about this later, that actually improving our technology to look into the brain and find specific abnormalities is one of our kind of biggest challenges for the future.
Thank you, Torsten.
Yeah,
So,
and if I can add to that very briefly, I don't know if this has happened in children as well, but in adults, there's definitely a group where there's multiple parts of the brain that have become too abnormal, which obviously means we're not going to take all of these different parts out because that's too invasive. So that is another group of patients where surgery would not be a real option.
thank you both. So it's quite clear that surgery can be hugely beneficial, but for a specific group of people living with epilepsy. Thank you.
It's currently, it's around 2/3 of the children who get referred to us. So like 1/3 is deemed not suitable at that time, yeah.
And roughly how many children get referred to you on an annual basis?
At our center, it's around 150 currently.
Wow, okay.
Per year, yeah.
Per year, wow. So a huge number, really. And if we can go back to both of the research that you've both been speaking about, I wanted to ask what the next steps are for this research and perhaps how long do you think it will be before this impacts patients? So Short, if we start with you, please.
Yeah, very happy to. The second part of the project that's been funded by Epilepsy Research UK is now underway, and this includes a study where we've taken all this information from our retrospective analysis from the last 10-15 years, and we've in discussion with the surgeons, we've tailored or we've redesigned their surgical approach to try and avoid these connections within the brain, obviously where they can. I think the main part of an epilepsy surgery should always be to try and keep the seizure, or to reduce the seizures or remove the seizures entirely, and this has to be the key aim. But where possible, we've told them what parts of the brain to avoid, and this is currently on the way. Obviously, due to current sort of clinical restrictions, it's not we're not doing as many surgeries within the national as we used to 2-3 years ago. But we're very hopeful that within the next year and a half, 2 years, we might have an update on this to say whether this actually benefits patients' language after their surgery.
Brilliant, thank you, Short. And Torsten, how about your research?
So one of the areas that we're particularly focusing on, and also together with colleagues at other universities, is trying to use artificial intelligence, for example, to find abnormalities in the brain that would otherwise been overlooked, for example. And that's a sort of a new technology that we're still currently in the process of trialing. So, for example, we have a clinical trial ongoing at Great Ormond Street, where this artificial intelligence is tested in a trial to see whether it adds new clinically relevant information for surgical planning, for example. So that we could see will be in perhaps clinical use internationally in a few years' time. and we're collaborating with many centers in the UK and around the world on developing this. So it's kind of an international effort.
Brilliant. Thank you both. And Rachel, another question that we ask our SHAPE network is, what one thing in terms of your epilepsy would be life-changing?
Something to be life-changing, definitely, for a child when overcoming surgery and recovering and everything, is in a way getting their life back and being able to be a child again, and like I said, explore everything they do and don't like, and make friends and find out their hobbies, and just yeah, get their childhood back and kind of not be interrupted by seizures.
Brilliant. Thank you so much, Rachel. And Sjoerd and Torsten, have people affected by epilepsy been involved in your work? And if so, how has this added value to the research? Torsten?
Yeah, to be honest, it has not been so much the case in the past, but increasingly now, when we design new studies, we are fortunate enough, even during the pandemic, that we can communicate with children and their parents and carers through social media, through charities such as yours, but also through the Young Epilepsy, where we can actually get instant feedback on whether a particular project is worth doing, what other things to consider, and also set priorities. And that's, I think it's a very important change in our culture that has taken shape, and we obviously fully support this.
Definitely. It's brilliant to see that things are changing for the better in terms of involvement, and maybe nowadays people, young children like Rachel was going through the surgery, can have the option to be involved, as you've said. And Sjoerd, how about involvement in your research?
Yeah, absolutely, Caoimhe. The patient involvement in the ongoing study, I think, is relatively limited, except for obviously patients being happy to contribute their time and be part of the research studies. But in shaping the research, the input has been invaluable. One of the co-investigators of the project and professor of neurology, Professor John Duncan, he's one of the co-founders of the Brain Buddies UK organization, which is primarily on epilepsy patients, which runs out of the National Hospital for Neurology and Neurosurgery, and it's mostly out of these meetings that he's led and he's participated in that we've highlighted language as being a really impactful part of surgical recovery. So it's pretty much informed us to do this study.
So brilliant to hear. Thank you so much, Sjoerd. And if anyone watching, if your life has been interrupted by epilepsy in any way, we also have the SHAPE Epilepsy Research Network, which could offer the opportunity to become involved in research into epilepsy. And we'll be linking the details of that just in the chat box below in a moment. And now I can't believe it's time for our final question already. So we ask all webinar participants this: what are your hopes for future research into epilepsy? So Torsten, if you'd like to start us off.
Yes, I mean, the ultimate hope would be to be able to offer a genuine treatment to all children who are affected by this. And I think the future will probably hold a mixture of better pharmacological treatments, but also maybe genetic treatments for some children. And we see some amazing advances in, for example, in children who have movement disorders and muscle wasting disorders, where gene therapy is really curative potentially. More immediately, I hope that through the collaboration with our partners at King's College and Imperial College and UCL, that we can harness some of the advances of modern neuroimaging. As I said, we're still on the hunt for better ways to image epileptogenic networks in the brain, and this is one of our kind of main new avenues where we hopefully collectively can improve the surgical workup of pre-surgical workup of children and adults, so I think being able to offer a really genuine treatment to all would be our dream and ambition.
Thank you, Torsten. Sjoerd, how about you?
Yeah, I fully agree with the previous statement. I think, especially in terms of surgical treatments, there's a lot of research going on at the moment to try and make every aspect of it better, make it less invasive, make it have less side effects, make it more available for everyone. Because at the moment, as we've said, quite a few of our patients that get evaluated or referred for surgery can't have surgery, and if this is their final treatment option, very often. It's a shame if we can't offer that to them.
Yeah, if I may add, for example, my colleagues are currently planning a trial to use deep brain stimulation. So even if you like, resective surgery is not an option, then to use some form of brain stimulation. You know that vagal nerve stimulation is already well an option, but other more innovative treatments are being trialed now. So it's there's a lot of, if you like, new excitement in the surgical field that some of these techniques will have a real impact on surgical outcomes.
Brilliant. Thank you so much. And last but by no means least, Rachel, what are your hopes for future research into epilepsy?
Yeah, I mean, I said before, I totally agree with everything that has been said already. So to reiterate that, if one day it was possible to form a surgery or have that kind of mixture with medication as well, to find something that works for every child or every adult, anyone affected by epilepsy, and even maybe tailoring that slightly to suit their even more specific needs, I think that would be absolutely outstanding one day. Yeah.
Of course, thank you so much, Rachel. And personalized specific treatments for people is something that we're hearing more and more about these days. So I think, yeah, that shows real promise for the future. So that brings our webinar to a close. A huge thank you to all of our speakers today for taking part in the webinar. Thank you to Torsten, Sjoerd, and a huge thanks to you, Rachel, and best of luck with the running and marathon training. We'll all be following your progress and cheering you on the day.
Absolutely. Hopefully meet some of you there, maybe.
Hopefully.
Yeah.
And so all of our speakers have also contributed to our research blog this month. And so if you're interested in hearing more, we'll be sharing the link to the research blog below. And the research blogs that we've heard about today are funded by our fabulous fundraisers who walk, run, cycle, bake, the list goes on. And they even organize their own fundraising events to raise money for vital research into epilepsy. Thank you to each and every one of you for your support. If you, like Rachel, have been inspired to fundraise, then why not take on our 6 for the 600 challenge? All you need to do is think of an activity based around the number 6, 60, or even 600, and your challenge can be anything you want it to be. So get your thinking caps on. Thank you to everyone for tuning in to today's webinar. Again, to our speakers for sharing their research and experiences with us today, and to James and Becca for ensuring that the tech runs smoothly. We're really looking forward to seeing you at the next Research Roundtable. So thank you so much for joining us today.